staff of Medicina. We are going to present about the evaluation of stiff hand. So, my objectives are, by the end of this presentation, you peoples will able to know the important clinical anatomy, that important clinical anatomy of the hand, or the important clinical anatomical structures that will lead to the stiffness, and how to assess the hand stiffness, and what are the conditions that cause the hand stiffness. As we are working in the burn department, and burn is one of the cause for the hand stiffness. So to know all these objectives, my outlines are scar, stiffness and adhesion, important clinical anatomy, common condition that causing the stiffness, assessment of the stiffness, questions and discussions. Scar. When you think about the scar, whenever there is an injury, definitely it is reprised by the scar tissue. Scar is very important in the part of the healing process. It is very important in the healing of the muscles, tendon, ligaments and bone. Whenever there is injury, definitely there will be the scar. So scar has the positive aspect as well as the negative aspect. The positive aspect of the scar is it holds the things together. The negative aspect of the scar is still it holds the things together. When you think about the hand, the structures of the hands lie each other, soft tissues. I mean the tendon under the skin and over the bone. When one injury happen, one scar happen, definitely it will hold and it will affect the mobility. So that's a negative aspect of this scar. Understood? Not the point. So adverse effect of the, so I like to know one thing. For example, you people's hand is normal. Am I right or not? There is no injury. Yeah.
Can you just repeat quickly from the beginning so I can catch up with you?
Okay.
Okay. Quickly.
Okay. Evaluation of the hand stiffness. To know the evaluation, my objectives are to identify the important clinical anatomy or the anatomical structures that kept causing the hand stiffness, and how to assess the hand stiffness and the common condition that can cause the hand stiffness. To meet all these objectives, our outlines are scar, stiffness and adhesion, important clinical anatomy, common condition causing stiffness, assessment of the stiffness, questions and discussion. Okay, ma'am? Okay. Then we discuss already the scar. So, your people's hand is normal. Am I right or not? Okay. If I am going to immobilize your hand for 8 weeks, after a week later, I just cut the POP cast. How many of you think that a week after the cast is removed, your hand will be still stiff? How many of you think? The hand will be, okay, stiff.
Yes.
After 1 week. After 8 weeks of immobilization, the cast, 8 weeks. Yes, most of the people think the hand will be stiff. I already asked you, your hand is normal. In the absence of injury, there is no scar. So your hand will be pretty good after 1 or 2 days after the immobilization. When there is injury only, okay, there will be joint stiffness, there will be tendon adhesion or the adaptive shortening. So we are dealing with the scar. Understood? So this is the 1 minute cause of the scar. So once after the injury, there will be inflammation. Okay, there are 3 phases: inflammatory phase, fibroplasia and remodeling. Once after injury, there will be inflammation. Blood is coming, they're preparing the part for the scar build-up. Just inflammation, phagocytosis, clear the dead tissues, everything. Just preparing the wound for the scar building up. Then second phase is like fibroplasia. Like the phase is like 5 days to 1 month. Then last phase is remodeling, like 1 month to 2 years. In the fibroplasia, okay, there will be rapid build-up of scar will take place. But scar is still we can be disrupted by the mechanical forces. The last phase is remodeling phases. It lasts from 1 month to 2 years. Still the scar will regenerate and reform, but can be deformed by the mechanical forces. Okay? So the scar is something like setting the concrete. If you allow to be like that, it will get stiff. Understood? Since we deal with the burn patient, one of the conditions that can cause the stiffness. Okay, after the sessions, we will achieve the full fist either passively or actively. But next morning when we come to see the patient will have the limitation. So, and once the patient gets discharged, okay, in the status report, the patient will have the full range of motion. Okay, the patient will be coming to the department after 1 or 2 days or based on the dressing day. maybe 3 days or 4 days he's not getting the sessions, still the patient will have the limitation. He will be in the same as the beginning. Okay, same like living the complaint. So trauma plus immobilization is equal to stiffness. The trauma is like fracture, distal areas, the extensors are passing, resulting condition. Immobilization can cause a stiffness to be like that. So how to prevent the stiffness? The best defense mechanism is to move as much as we can. That's why we give the patient home exercises, home instruction. If there are patients because of the pain, laziness will not do, so end up in the stiffness. So best defense mechanism is to move the part as much as we can. So important clinical anatomy of the hand. Anatomical structures. We are going to discuss not the thumb. We are excluding the thumb. We are going to discuss about the MCP, PIP, MCP collateral, PAP and the volar plate, intrinsic muscles and the extrinsic muscles. Through this clinical anatomy, we will find out how these structures are causing the stiffness. Okay? So MCP and the collateral ligament. Whenever there is an injury, we should give concern to the MCP and its collateral ligament. Can you do like this? Okay, or like this. Try to separate the fingers. No. By flexing the MCP, after flexing. Okay. Try to separate them. Okay. Do like this. Easy. The reason, why?
Ligaments.
Huh?
Ligaments.
Okay, ligament. What will happen to the ligament?
Swell the bones.
Okay. It is like loose in extension and
Yeah.
taut in flexion. Okay. So whenever there is an injury to the MCP or collateral ligament, we should immobilize the structures in like 70 degrees or 90. That's why you call functional hand splinting. Okay. Like 70 degree, 90 degree of MCP flexion. Once we lost the MCP flexion, then good luck in getting it back. Usually once it's lost hyperextension, the surgeons are doing the care and fixing the MCP. So better concentrate the MCP and mobilize as much as we can. Then the PAP and the volar plate. Volar plate is something like piece of soft tissue. For example, I'm drawing my middle phalanges. This is the proximal phalanges. Okay. Volar plate is something like piece of soft tissues and the tail is running downwards. Okay. Piece of soft tissues over here and the two like tail is running downwards. So it gets short in flexion, understood? It gets stretched in extension. Usually it gets injured by the hyperextension injuries. When a ball gets hit, it can cause the stress of the volar plate and cause the injury. So whenever there is an injury, immobilize the PIP in neutral position. Okay, if it is like this, it can cause the tightness of the volar plate, later like stiffness and became the contraction. So PAP and the volar plate. The other structure is oblique retinacular ligament. Oblique retinacular ligament, by the word itself, it sits obliquely. Okay, sits obliquely. This is the PAP and this is the DIP. Oblique retinacular ligament, like volar to the axis of PAP and dorsal to the axis of DIP. Okay, sits obliquely. Volar to the axis of PAP and dorsal to the axis of DIP. It supplement or it in contribution with extensor tendon, it helps in extension of the DIP joint. It helps in the extension of DIP. For example, look, this is the oblique retinacular, my PIP. Okay? Look, it finds difficult in extending the DIP because the oblique retinacular ligament is in slack position, loose position. When I extend with the help of the extensor tendon, it gets tight, it pulls the DIP. So it supplement in extension of the DIP. So for example, hand stiffness, okay, limitation. This is considered as full fist. If the oblique retinacular ligament is tight, it will not be like this. It will be like this. The patient finds difficulty in flexing the DIP. Ask the patient to make the fist, it will be like this. It will be It will not be like this, it will be like this. One of the reasons is the tightness of the oblique retinacular ligament. So how to test the oblique retinacular ligament tightness? Okay, oblique retinacular ligament is tight. It flexes the PAP and extends the DAP like buttonhole deformity. Flexion at here, extension at DAP. How to test it? Okay, I receive the patient, PAP is tight. If I extend, by extending the DAP, I am making it more loose, so I will gain more range on PAP. If I flex the DAP, it is get tight, so more limitation at the PAP. Got the point? Okay. So intrinsic muscle. When you think about intrinsics, we are just not mentioning about the lumbricals, palmar, and dorsal interosseous. Lumbricals. Lumbricals origin from the radial side of the flexor digitorum profundus. Okay, doesn't matter, and it pass volar. Lumbricals pass volar to the MCP, volar to the axis of MCP, and get attached to the lateral band of the extensor tendon. It pass volar to the MCP and get attached to the lateral band of the extensor tendon. So lumbrical action is the flexion at MCP and extension at PAP. Okay. Same like the palmar and dorsal interosseous. Palmar interosseous help in the adduction. Dorsal interosseous help in the abduction. Doesn't matter. They may sit palmar interosseous like adduction. One on here, and one over here. Dorsal interosseous abduction. One over here, two on either side, and one over here. Doesn't matter which side they sit. Anyway, whatever side they sit, they pass volar to the axis of MCP and dorsal to the axis of PAP. So this palm, like lumbricals, palmar, and dorsal interosseous, help in flexion of the MCP and extension at PAP. Got the point? So long flexors and extensors. Extrinsic flexors means long flexors, that muscle that originate without the hand, not within the hand, from the elbow. But flexors pass volar to the axis of MCP, volar to the PAP and DAP. So the flexors are tight, it limit in extension of the MCP, DAP and DAP. And the long extrinsic extensor tendon pass dorsal to the axis of the MCP, PAP and DAP. So when the extensors is tight, it limit in flexion. Okay. So draw the extensor mechanism. Extensor digitorum hamnis is coming like this, trifurcate. This is the central slip, this is the lateral band, passing like this, and it's a terminal tendon. Extensor digitorum is coming, okay, trifurcate, three. One is the central slip and two lateral band, then uniting, getting attached to the DAP, okay. So MCP is going like this, getting attached to the lateral band of the extensor digitorum camulus. Okay. So EDC sagittal band. Sagittal band is something like fix the EDC extensor digitorum camulus over here. Common injuries causing stiffness like hand fractures, wrist fractures, tendon injuries, crush injuries, volar plate injury, MCP collateral ligament injury, infection, fight bites, osteoarthritis, and the burns, as we deal with the burn, carpal tunnel syndromes and tenosynovitis. Assessment of the stiffness. How to assess the hand stiffness? Stiffness means limitation in the passive range of motion. Limitation in the passive range of, whenever we measure the stiffness, just go to the passive range of motion. How can we measure the stiffness? Like passive range, using the goniometer. So we use the finger goniometer to measure the passive range of motion, keeping the goniometer on the dorsal side of the hand. Okay. When we use the goniometer, don't measure all the MCP, all the PAP and DAP. Just concentrate on one finger. Altering the position of the joint, the patient can gain the more range. So it is like cheat. So when you measure one finger, just keep the goniometer on MCP, PAP and DAP of one finger. So notations used in the goniometer are like 0 means neutral position, or extension. Negative means extension lag, and positive means hyperextension. So stiffness, the main four cause for the stiffness, either the capsular causes or periarticular structures, either the intrinsic muscle or the extrinsic muscle or oblique retinacular ligament. These are the main cause of the stiffness. Okay, capsule and periarticular structures, intrinsic muscle or extrinsic muscle, and oblique retinacular ligament. How to rule out this stiffness? How to find out this? Okay, how can I know whether capsule is tight? How can I know whether intrinsic muscle is tight or extrinsic is tight? Just move the adjacent joint. For example, if the PAP is stiff, just move the adjacent joint, either MCP and the DAP. So we make some structures loose and we make some structures tight. From this, we will be able to know what are the structures that can remove the stiffness. For example, if the joint capsule is tight, is stiff, if we move the adjacent, for example, the PAP is limitation. If I move the adjacent joint itself, there will not be any change in the range. For example, I measure the PAP as minus 15 degree. Extension is limited. If the joint capsule is tight, when I move the adjacent joint, that is like DAP and MCP, there will not be any change. It will be remaining same. So it is like joint capsule means if we move the adjacent joint, the range will be remain same. And the muscle, for example, if intrinsic muscle is tight, if the intrinsic muscle, umbilicus, palmar and dorsal cruciate is tight, it will limit in extension because it passes forward to the axis of MCP. So it limit in extension and limit in flexion. Okay, limit the flexion PAP. If the long flexors is tight, it limit in extension. If long extensors is tight, it limit in flexion. You will able to know more about this, how to rule out it by going through these examples. For example, the John has 30-degree limitation in PAP flexion. So it can flex the PAP passively up to 70 degree. For example, PAP range is like 70 degree, like 100 degree. It may vary from 100 to 120 degree. As we go side, the range increases. So PAP, for example, for index finger, it can flex only up to 70 degree. So what will be the cause for the limitation at PAP? For example, when you think about the PAP, it can be the joint capsule. It can be limitation. I mean, not able to bend foot. Can be joint capsule. It can be long extensors, and what else? And the intrinsic muscle. And how to rule out it? For example, if the long flexors are tight, long extensors are tight, if I flex the MCP, the limitation will be more because it is getting more stretched. The long extensors are tight, the limitation 70 will be limitation, only can make it only up to 50 degree, it will be more limited. If capsule is the reason, if I move the MCP or the DAP, it will remain the same. If the lumbricals or intrinsic muscles are tight, if I extend the MCP, it will be feel more limitation. Got the point? Because we are stretching the lumbricals. Okay. So if I extend, it will be more limited at the PAP. So another example. Passive range, PAP range minus 30 out of 110. Like minus 30. That means the extension lag. Like this. Not flexing, we find difficulty in extending. What will be the reason? Capsule is there. Long flexors are there. Long flexors is passing so it can go by the long flexors or oblique retinacular ligament because oblique retinacular ligament pass from here. Okay, so these three reasons. How can we rule out it? If the long flexors are tight, if we extend the MCP and extend the range, it will be more limited. For example, if the capsules are tight, if we change the adjacent joint, there will not be any change. If the oblique retinacular ligament is tight, if I flex it, it gets stretched. Oblique retinacular will get stretched, so it will be more limited. oblique retinaculum pass from here to here. So if I flex it, I am stretching the oblique retinaculum ligament, so it will be more limitation in extending the PIP. Third example is saying like the MCP range is minus 30 out of 90. Can you tell someone the minus 30? MCP range is minus 30 out of 90. Okay? Tell me the cause. Minus 30 means not able to make full extension. Okay? What will be the cause?
Maybe once they're short.
Three factors are there. Oblique is not passing the MCP, from the PAP only passing. So definitely it will not be. Definitely capsules are there, long flexors are there, then the intrinsic muscle. Because intrinsic pass like this and get attached over here. Okay. For example, if the long flexors are tight, just extend the wrist. If I feel more limitation, that means long flexors. If the intrinsic are tight, just extend the MCP. It will stretch the lumbricals and intrinsic muscles. So it will be more limitation. Or just flex the PAP. Passively. Passively flex the PAP, it will feel more limitation. The capsule will not be any change. So conclusion, what will be the conclusion? Definitely we receive the patient with hand stiffness and we start mobilizing when we found there is a limitation in the passive range of motion. But by knowing what are the structures that causing the limitation only, we will able to get good result. Thank you.
How many patients you've treated with stiff hand?
Like burn patient, the thermal, like flame burn. Hand is the one of the most part get injured. For example, today there's two admission for me. One is like 45%, one is 100%, 95%. Don't think about the 95%. The hand, they do the scaratomy. Means that is deep and swollen. Okay. So most of the burn patient will be affected with hand.
So you have so many patients.
So many.
Why you didn't videotape one of them for us, for the lecture? I didn't see any good audio visual video. Hmm? Do you think it's important to show us a real case? All what you've tell us is wonderful, nice information. But I think most of us, when we walk out of this door, 90% of your information will be lost. But if you show us something in practical, especially a real patient, with a real stiff hand, what you are doing, a good job, an amazing job with them, I think it will stick in our mind for a longer period. And it will be easier for you even to show us what you mean and why this is so important to know about the ligaments, the intrinsic muscles, the capsules. Yeah. So it's really not practical unless you see it on a real patient. So I encourage you all, not only Sanush, now you are now in this position, but for the others, specifically if you are talking about a specific kind of case or disease or disorder or whatever, I would like it to come from the real patients, because I think you brought this material for us today because you are facing this with your patients. So you wanted everybody to know about it and to know how to assess the hand properly in order for you to set the right goal and set the right program. But if you show us for the real patient, before and after, and how the evaluation is important, because we are always focusing on the treatment. But evaluation is very important for you in order for you to set the right treatment plan. How would you treat something you don't know how to evaluate it? Or you don't know the origin of the problem. You have to know the origin of the problem in order for you to set the right. Why you are choosing this technique, you are doing stretching in this position, you wanted to do splinting or something. And one thing else regarding evaluation, are you using any scales?
For stiffness,
And not only John meter, as an objective measure, something with numbers.
Just you should
Johnny
monitor.
Meter?
Johnny Meter,
Do you have anybody else familiar with any scales?
No, like for a functional assessment.
Functional, yeah.
Functional, okay, there are different tools, like OTR, dealing with different tools, and we use the strength also. Yeah.
Okay.
Not only the PROM, we can
Okay.
measure the AROM.
Any scales? You have any
For
scales?
the hand function, tip to tip, pad to pad, tripod, we use
Ah.
pinchometer.
Okay.
For the fist, we use
Dynamometer,
dynamometer.
pinchometer.
And if the stiffness with edema, we use the inch-tape measurement for the edema assessment.
Again, I'm asking about the scale.
Scale is gonio.
Dynamometer, pinchometer, yeah.
Old barometer should be that's not scale, it's a measurement.
It's like an outcome measure. Outcome measure.
Scale is different than measurement.
We are not only OTs are doing.
No, these are measurements. Okay, these are measurements.
Alright.
Okay, but scales. That. Okay. Okay, any other scale? Anybody heard about something called the HISS? H-I-S-S?
Yeah, we know about last time lecture.
Which one? It's the hand injury severity
Scale, yes.
scale. Okay? Anybody heard about it? You heard about it from where?
Some lecturer I heard about.
Here, lecture? Here? Somebody presented. Somebody. She's the one who presented. Surely not.
No, I understood. Yes, very
You
good.
and-
Yes, and myself, I don't know.
Yeah, oh my
Indian
God.
students.
Okay.
Indian students.
Maybe India, sorry.
This is also a good scale, maybe you can go through it. Okay, and it's also to, I think it has two parts. And one is functional, while the other one is something else. I'm not sure, but I read about it a long time ago. But I still remember it. Yeah, hand severity, HISS, yeah, hand injury, severity scale. Yes. Okay, just go through it. And maybe to use objective tools regardless of the meter and muscle power and everything, this is obligatory. You have to do it. But to do something else, especially if there's an interesting case, use another variable, the one that you are not used to. Something else, okay? And read, guys, huh? Read. And inshallah, for next time, for the others, inshallah, I'll be trying to attend every lecture, yani. I would like to see some audiovisual more than that, okay? The topic is nice. You went deep into it, which is very nice. This is what we are aiming to. But please, yani, you use more audiovisual, something that you videotape. Your patients, take their permission. And if it's the hand, you can only videotape the hand, no need for the face to show. Not just to use audiovisual from the net. Something you did with your patients, okay? Shows the real result. The results of your treatment, your evaluation, whatever. Encourage everybody to do this, okay? And share with us. It will be more beneficial. Thank you so much.
Thank you.
Thank you.